decided to focus on the justice-involved population as part of your planning with the new cycle. Part of the reason why that is so critical is that we know that if you are involved in the justice system, it carries tremendous risk for higher smoking. So about 4 times the prevalence of the general population. And that's even out after accounting for other demographic risk factors. So even if we were to rule out, the crossover with behavioral health conditions and low SES or living in poverty, for instance, there's still, these individuals are going to still smoke at a very high rate. And that's why it's just, again, such a critical population to focus on. Next slide. So let's just get into some basics and go ahead and around the Quitline and why the Quitline is such an important factor, such an important resource in when we're trying to help people quit smoking and maintain their abstinence over time. Overall, we know that for this population, whether it's behavioral health or for criminal justice, quitting tobacco is absolutely feasible for people with health disparities. But really to get there, we need to make sure that the dose of evidence-based assistance provided really meets the dependence level and the unique needs of each of these subpopulations. Next slide. And so to do that, really what the evidence base is telling us is that we need to approach tobacco cessation from a medication-assisted treatment perspective. So this is saying that if we're going to be the most efficacious in the interventions that we're using, it has to be a combination of those behavioral health or behavioral interventions, behavior change interventions that we know are proven, as well as the medications that we know are proven as well. And so, when we talk about MAT, typically it's coming from the opioid epidemic world, from other addictions, and so forth, but there's absolutely no reason why we shouldn't be referring to tobacco cessation as MAT as well. So it really, we're talking about the same thing, that combination of behavioral strategies and medications. Next slide. So nationally, because I know most of you are aware, there might be a few folks on the call today that aren't too familiar with the Quitlines, but I think that a lot of you are fairly familiar with the Quitlines and the fact that this is a national initiative. If you go to and were to call 1-800-QUIT-NOW, you would be connected to your state Quitline in any state out there. And so very, again, supported by the CDC and a very proven intervention. Next slide. And I just wanted to kind of share a little bit of the history and what the Quitlines overall provide. And so each state is distinct, and when Mark and his team come on talking about the ASH line, they can fill in some of the details about what specifically is offered in Arizona. But my job is just to give you the general overlay nationally about what Quitlines are. And you can see that the Quitline started around 1992 with just a few states, and Arizona was one of the first that was on board in creating a Quitline. But you can see that growth over time, and by the time we get to 2006, if you look at the figure on the right-hand side, all of the states again were on board and now have Quitlines. And what they offer is some amount of subsidized cessation coaching and medications. And the amount of counseling and coaching really does differ by state, but if we looked at an average across the nation, we're talking about offering about 5 coaching sessions, and then some degree of medications that are offered for free. And these can be really it's really dependent on the resources that any given state has in any given time. And so, at some points in time, states are widely able to offer these services and medications. Other times, the resources and the funding is quite limited. And so states really have to make choices about what populations they're focused on, how many coaching sessions they're going to offer, and what degree of medications they can offer, if they can even offer medications at all. On the Quitlines, most of the coaching is delivered primarily telephonically. But at the same time, almost every Quitline has some presence on the web. They're using chat functions, they're using texting functions, and really exploring whatever some of the new platforms are that are emerging right now. Quitlines are funded by a variety of different funders, and so the state or local funds, CDC grants coming through the states are often really the largest part of funding for Quitlines. Tobacco tax dollars come into play, master settlement agreement monies, and then public-private agreements. So when I say that, I meant that the Quitline is working with, say, other third-party insurance companies or companies, and they are paying for the ability to use the Quitline service. So what the Quitline, as I mentioned, a core component of that is the medication offerings. And this, what we found is really, this is one of the probably the primary way that we're engaging individuals into calling the Quitline is this medication offering. So what you're really seeing here is that Quitlines do offer the full gamut, if you look across Quitlines, of the 7 FDA-approved medications. Of course, they're going to be much heavier on that left-hand side on the nicotine replacement therapies like patches. But there are handfuls of, and then there's the prescription NRT2 that really isn't offered that often. But then if you look at the non-NRT medications, so that's bupropion and varenicline, there are a handful of states that are also offering that as part of their benefit to callers. And so if we look at justice-involved Quitline callers, and we can go to the next slide, there really are a lot of challenges and some context that we need to just be aware of as we're talking about Quitlines. And this again applies equally to the behavioral health population, among some other subpopulations like whether it's pregnant moms, perinatal moms, etc. But of course, the pandemic right now is really a challenge, and it's really sapping the resources from states and really challenging them to offer, more or the same level of Quitline services that they did pre-pandemic. But there's always other competing issues that are coming up as well. So that's just something that really affects the state and the federal budgets and ability to offer these services. Reach is a real issue across the most vulnerable populations. So if we're talking about the justice-involved individuals, reaching them is really difficult, and really looking at effective ways of not only reaching them, but helping them to reach out and both call, have those resources to call, enroll, and sustain and finish their counseling sessions. So that's really something that we've been working on, looking at how we can increase reach across a variety of the most at-risk disparity groups. Also right now, and this has really been pushed forward dramatically with the pandemic, is telehealth versus telephonic. So again, Quitlines historically are telephonic services, but there's a lot of telehealth right now, as everyone knows. And through telehealth, a lot of different agencies and hospital settings, states are looking at how they can offer tobacco cessation through telehealth as well. And so this is just something that right now and in the future Quitlines have to grapple with regarding, they have their historical platforms telephonically, but how much do they need to get into the telehealth world what are the impediments to that, and so forth. And then again, historically, there's a lot of barriers that we face, and we're always trying to kind of grapple with, and it doesn't matter what state it is. All states are grappling with a variety of these. So there's things like preauthorizations. So if we request preauthorizations for folks that go to the Quitline, they have to get a pre-auth to then go get their medications. It's a serious barrier. And there's a variety of other barriers like that we just are seeking to overcome. And then there's also just fragmented care and gaps in care that dealing with fragmented systems. So in the behavioral health world, we've started to tailor treatment to the Quitline treatment to these individuals. And again, we're talking about justice involved, but there's such a crossover with behavioral health that they might really kind of be, when they call, they might be routed into this tailored treatment for behavioral health in a variety of states. And I know that Arizona is looking at behavioral health tailored treatment as well. And this can be in regard to changes in staff training, supervision, looking at making sure we're screening for behavioral health conditions, offering greater intensity of services to meet dependence levels, really focused on patient-centered and strength-based and services and care coordination, maybe greater duration of treatment, and then really integrating some things like cognitive behavioral therapy and mood management and motivational enhancement to help those folks with behavioral health conditions more effectively. And if we look on the next slide at the states that have implemented this behavioral health pilot programming, there has been a lot of successful tailoring. The abstinence findings themselves, so how many people are actually quitting and staying quit, are mixed. But at the same time, what we're finding is that these behavioral health interventions are leading to increased engagement. These callers are using more calls. They're using longer durations of nicotine replacement therapy. And there are definitely feasibility considerations in place, but the tailored programming does look like it's lending to a lot of potential gains. And next slide. And so with that short introduction, what I want to do is really have Jim have enough time to really talk about some design considerations for getting in and making appropriate referrals to the Quitlines. So Jim, go ahead and take over.
Great, thank you, Chad. So what I'm going to go into now is, as the slide says, I'm going to talk about some design considerations if you're making a Quitline referral process. And before I start in onto what I mean by that, I want to say two things that I want you to keep in mind so that you can appropriately hear the things I'm saying. The first one is that if you go to the Quitline more broadly, if you go to Quitlines across the state, if you go to the North American Quitline Consortium and ask them who is an appropriate referral, they will tell you that there's no demographic subpopulation that Quitline referrals or Quitline services don't work for, broadly speaking. They all work within a range, but they all work equally well across whether we're talking about gender differences, sexual orientation differences, racial, ethnic differences, et cetera. And they have specialized protocols for a variety of specific populations that can really bump up rates, which is to say that from their perspective, generally, everybody's a good referral. And I'll let Mark at the end talk about the Ashline's decisions along that particular measure. So when I say you might want to consider who you're referring, don't consider it on behalf of the Quitline. You will be considering it just as your own organization or your partner's capacity warrants. And then the other thing is that, although I said that we're going to go kind of in the weeds, keeping in mind that the weeds here are really going to be determined by things that are happening in the hallways of the organizations that are making those referrals. So these are just sort of some of the things that can help outline what a good strategy is going to look like, and then implementation is going to alter how we appreciate those things. And I'll get to that part of it in the end, and how we sort of look to reality as our guide. So the first thing that we want to talk about is education versus services and supports. And generally speaking, and I've said this before, education is a necessary but insufficient intervention for getting us prolonged and sustained quit attempts. What we really need to be doing is connecting people to services. And the services that we're concerned with here are the ones listed at the bottom of this slide, which, if this is not your first presentation with us, you have almost certainly seen before. These are the services that have been rated an A by the United States Preventative Services Task Force, which is to say that they have a very strong evidence base for working. And the way that we're going to connect individuals to those services appropriately is to put them through a sort of services delivery framework. And the one that we always recommend is the 5 A's. You might be more familiar with SBIRT. There are others. But the real crux here is that we're screening everybody for exposure to tobacco smoke. And then given certain characteristics of how that exposure occurs, we're advising them to quit or to reduce that exposure. And then we are connecting them to services as their own wants and desires and needs dictate. And specifically in regard to today's conversation, we're talking about referring people to the Quitline. So I've reduced the 5 A's on this slide now down to the 2 A's and an R. You've heard me before say I generally only teach the 5 A's because the 2 A's and an R are really only an evidence-based best practice as long as the person is getting the other 3 A's at the point of care that they're being referred to. When you're referring somebody to the Quitline, if that person gets enrolled, they're getting the other 3 A's. So this is an evidence-based best practice. And the way that we're going to begin thinking about revising this sort of standard high-level protocol to get everybody into the Quitline, we're going to actually do a little bit of assess and assist to make sure that we think that the Quitline is appropriate for them. And part of that, by the way, is we're going to say something like, do you want a referral to the Quitline? And if they say yes, then it's an appropriate intervention for them. And then once we refer them, we're going to initiate a tiny bit of follow-up to make sure that they get enrolled. And if they do get enrolled, we want to say something like, how's it going? Did you like it? Did you get your meds, etc.? So what I want to do now is kind of move into setting the stage for success. And these are all, I'm going to talk about each of these in turn. So I'm not going to spend any time on this slide doing that. You'll see as we go through that I'm going to keep referring back to this slide. And the first thing we're going to talk about are the your organizations or your partners' organizations' criteria for referral. There are a lot of different ways you might limit your workflow by limiting how many people you actually go through this process with. One of them is the level of interest in quitting. And here I mean something as simple as asking somebody on a scale of 0 through 10, how ready they are to quit, how motivated they are to quit, those kinds of questions. Or you might just say like, are you interested in a Quitline referral? And that would be a level of interest in quitting by this particular intervention. And to everybody who says yes, or everybody who's, up to your organization, but maybe everybody who's above a 5 on a 0 through 10 scale of readiness gets referred, and people who are below that might maybe get an educational intervention or just patience. The level of dependence. The higher somebody is on a validated instrument of dependence, the more critical we might think of that referral. So somebody who is really lightly dependent, a scale, a 1 or 2 on the Fagerstrom test for nicotine dependence, for example. Maybe we think that the Quitline is too intense of a service for them, bearing in mind, as I already said, that the Quitline thinks that everybody's a good referral, generally speaking. So just on your organization's behalf, if this is a sort of workflow capacity issue. If somebody is suffering from pretty advanced or complex medical and psychiatric complications, which is to say, it kind of ties into the next bullet point, that it might be the case that somebody's in a situation where quitting tobacco is of imminent concern. And so whereas before in some of these earlier bullet points, maybe we're leaving it up to the client to tell us whether or not they're interested in quitting, or if they're interested in quitting via this method. In this situation, we might just say, you know what, this person's going to get a referral regardless of whether or not they want it. It'll be up to them if they enroll or not. And then finally, staff constraints kind of goes along with clinical priorities. But with staff constraints, we're really talking about education, ability to make these referrals in an effective way, also time. How many people can they effectively actually refer? And clinical priorities might be a situation where this year we're going to focus on all of our patients with diabetes, or in the case of the people on the line here, we might say anybody who is in a drug diversion program. Maybe they're going to automatically get this referral, that kind of thing. So that's our organizational criteria for referral. Now we want to move on to estimating our workflow burden. And I'm not going to belabor this point because I know a lot of you have already seen this before, but this is actual data from survey data that BHWP collected across residential substance abuse facilities in Florida. And the first thing we're going to say is it only takes a second. We're going to screen literally everybody. And in residential substance abuse in Florida during for this survey set, we found that about 17% of folks entering treatment for substance abuse were never or non-smokers, which means that we're going to advise 83% of those individuals, that's 83 out of 100 of those individuals, that quitting is the best thing they can do now for their health now and in the future. And then we're going to assess their stages of change. And what we found in our survey is that about 29% of folks had zero interest in quitting. And therefore, the other 54 individuals we're going to actually make a referral for. That's how we would estimate how much time and how much labor we'd be putting into this effort. From here, we can kind of do a quick time analysis, associate that with our FTE, and then kind of have a pretty good or a rough sense of what we should be expecting every, say, month or every 2 months, every 6 months, whatever. Then if our Quitline offers it, and maybe Mark can speak to this, a lot of Quitlines offer what are called faxbacks. That is, everybody who's referred to the Quitline, or at least fax referred to the Quitline, it varies depending by the state. If that entity that makes the referral is a HIPAA protected entity, the Quitline can give them faxbacks, and the faxbacks will tell you the enrollment status of those who've been referred. That is, were they unable to be contacted? Were they called and decided not to enroll? Were they enrolled? And then depending on the responses we get from those faxbacks, we can reach back out to those individuals, as I already said, ask those who didn't enroll what happened and see if we can correct that, whatever that barrier might have been. And if they did get enrolled, we can follow up and ask them how it was, and really showcase that this is an integrated approach to their tobacco cessation attempt, that we're all in this together as a team. Then we move on to determining who is referring to the Quitline. And again, this is a topic that we've covered before, but some task or set of tasks that might be experienced as a heavy burden on one person can be significantly, the load can be significantly lightened if it's spread out across a team. Sorry, I don't know if you guys can hear this. I've been assured that you can't, but I'm getting a new roof today, and so I'm really distracted, and I apologize when I stutter. Sometimes the noise here is very loud. What you can see here on the far left, the third box down is where we say fax, Quitline referral, and preauthorizations. Chad mentioned preauths before, but which is to say that a Quitline referral can be done by an intake staff. It doesn't require a clinician's education or training in order to fax a form into to the Quitline. But you can also see that if somebody's adopted either the 5A's model or the 2A's and an R model, if you look at that black line that separates those two right-hand boxes and follow it all the way down, the second to last box on that line is preauthorizations and referrals, which is to say that the referral process itself can exist in either the 5A's or the 2A's and an R model. And all we have to do at this point is instantiate who that actual individual is. And I do encourage organizations to name those people or that person or those people literally by their name, and alternatively by their title or position. You might just have somebody who sort of always fills in the role of quote unquote peer navigator, and then that peer navigator, whoever that person is, would take on that function. So then we move on to benchmark setting. And if you're in attendance at the last webinar where we covered data in benchmarking, I'm going to sort of repeat myself very briefly, which is to say that we don't always know where our benchmarks come from. It's not always intuitive. We can't pull them out of the sky. And a lot of the resources that are available online are for national audiences, or they're for statewide audiences. And no matter what, we're never going to have somebody, well, for the most part, we're never going to have specific actionable data about the organization and the population that organization serves that we can just sort of pull out of a hat and just run with. So we do encourage people to go ahead and access our website. There's other websites out there, of course, and look at what the general trends are and sort of make your own assessments. Say things like, well, if the national prevalence figure is 15.5, but our state prevalence is 14, we can assume that in general, the state's doing slightly better than national. So then you take any national figure and sort of reduce it by an equivalent amount and say, okay, well, this is a good starting point for us. Since we're talking about Quitlines, I want to point out these two resources that are on this slide. One of which I helped author. It was like my first or second assignment with BHWP was about increasing low-income callers' access and utilization of the Colorado Quitline. We accessed quite a bit of national data for this report, and then we also did focus groups across a variety of demographic groups here in Colorado, focusing on low SES callers. So it's a little bit more of a refinement if you're working with a low SS population, and since you're working in criminal justice, that's going to apply. We also, most recently, my colleague Derek Nolan helped author this report in blue, the National Jewish Health Project Rural Quitline Evaluation, and he was able to do several focus groups in rural Nevada, so your neighbor. So again, a situation where we're going to refine those national figures for an audience that's a little bit closer to the ones that you're probably working with. And those will be a good way to help guide how you assess and evaluate and refine those national figures for your own organization standards. You're not done. After you've done this step, when you set those benchmarks, you might readjust those benchmarks if you're really overshooting your goals or really undershooting them. Then we're gonna let reality be our final coach here. So moving on, we want to make sure that the relevant staff is trained. And I'm just going to hang out on this slide for a second because it's worth considering who's relevant staff. I would say at a very basic level, everybody in the organization is relevant staff. Everybody in the organization should know that referring to the Quitline is now a service that you are providing. They should have a good understanding of why that decision has been made, how it's going to help the people that that your organization is serving or your partner's organization is serving, and some assurance that the Quitline does in fact work with that population. And we want to talk about the Quitline and the goals of the Quitline in terms of the values and mission of the organization that we're partnering with. So you're going to want to talk about how the Quitline or how cessation in general can help people in their substance abuse recovery. You want to help, or you want to explain that cessation from tobacco can help stabilize mental and emotional health related issues that might lead to criminal activity, that sort of mental health activity that happens in public and might attract the attention of law enforcement. So we're having a sort of indirect effect on recidivism rates and making sure that people can come back for their court ordered appointments and those sorts of things. Cessation is a way of supporting our partners' organizations' overall mission and values. Where that education comes from ranges in intensity. Again, I'm going to point you all to our website, resources that I know you know exist. There's just a few here, but we have really dozens of toolkits and addendums, and you can also go to our YouTube channel and get webinars. And of course, what I actually should have made a slide for all the webinars and presentations and resources we put together for this Arizona community of practice, because a lot of those resources are a lot more local and maybe more useful than the national ones you see here. There are more intense efforts. Actually, the Arizona community of practice is very similar to the Build a Clinic program in the sense that we have done a series of tailored webinars. In the case of the Build a Clinic program, it was more broadly focused on primary care and integrated care clinics in rural areas. But you know, work with us, and we'll figure out the topics that would most benefit you. And you can always adjust our future presentations by giving me an email. You know how to find me. Finally, once you've talked to a bunch of people, you really kind of know what your goals are, you can just reach out and just do it. Just do it. The only way to really know how to adjust the Quitline referral process that you're trying to design is just try to do absolutely anything and see where the problems are. A lot of the problems are just going to be, honestly, at the very beginning, just getting people to remember that they can do this, that they can make these referrals, that this referral is an option that they now have, and remembering to extend it, right? Remembering to screen people when that's the new thing, right? Like just asking people, are you a smoker? And saying, oh yeah, there's a resource I can connect you to for that. Once you get that out of the way, once you get that burden sort of resolved, then we can start to figure out like simple things like, maybe do we have enough fax referral forms? Where do we keep them? Are we making people print them out on their own? Can we autofill those things? Like there's a lot of sort of fine tuning that you can do to make this faster and easier and more likely to be done. But the only way to figure out which of those things you actually need to do in your organizations or in your partners' organizations is to just try without that knowledge and see what presents itself. And then finally, you want to adjust. And I've alluded to this several times, and I'm about to close here. I have one more slide after this, or two more. I have two more slides after this. You want to take your benchmarks. You want to make sure that you're being honest with yourself about whether or not you hit those benchmarks and why. Right? And not just why you didn't when you didn't, but also why you did when you did. You want to emphasize those parts of the program that work, and you want to change those parts of the program that don't work. And you want to be honest with yourself, make sure you're taking credit for the things you actually did and not taking credit for things that happened around you. And vice versa. You don't want to take the blame for things that you didn't do too. Or for right now, if you had for some reason decided that prevalence rate of smoking within a specific drug court or probationary program was a measure of success or failure, well, then you're going to be really disappointed in your results if you'd been measuring for over the last 5 or 6 months, because prevalence rates are going up. But your program didn't do that. COVID did, right? So you don't want to take the blame for things that you didn't do, but you also don't want to take credit for things that you didn't do. And the opposite example of that is suddenly you used to be making 25 referrals a month, 25, 25, 25, and then suddenly they spike at 50, and you're all patting yourself on the back, only to find out that the CDC Office of Smoking Health has been running a ad campaign for the Quitline, or the Tips from Former Smokers campaign. Right? You don't want to take credit for anything that you didn't do, because you're going to accentuate things that don't work. So anyway, belabored that point enough. I'll move on. We do always encourage a learning health system, or creating a culture of continual improvement, however you want to define that. We always encourage folks to adopt something like PDSA. We like PDSA. We can train and teach on PDSA. It has a long history of success in the healthcare industry as a way of making these sort of rapid improvement changes. But it doesn't really matter what you adopt, as long as you adopt something that is explicit and explicitly designed to improve your patient client outcomes. The form on the right there is our Dimensions Action Plan. This one is actually filled out with an example from our Build a Clinic program. The ones we have available on our website are blank, and you can fill them out online. They basically ask you to pick 2, 3 to 6 month goals, identify at least one barrier to that goal, and assign accountability. Who's going to be responsible for on a specific date for whether or not that goal was achieved or not. You don't have to use this form, but it is a way of thinking about how we do rapid improvement, which is to say we make SMART goals, we assign accountability, we assign deadlines, we look at our barriers, and we make sure that the barriers themselves don't need their own program to resolve. You'll see that the second barrier listed on the sample on the board is time. Well, you can't create time. So what happens to that goal if in 3 to 6 months they don't have time? Right? So how do you resolve that we don't have enough time? Well, there's a couple ways. One way is to just assign people the task. Just say, you're going to do this. You're responsible for it. You'll be reporting to me about it in our supervisory meeting. So you put something in the supervisory chain. The other way to solve time is to hire people. And if that's not an option, if neither of those are an option, then time is not a type of barrier that's going to resolve itself. So I would have recommended to Tracy and Mary Karen that they needed a different goal. Okay, that's the kind of thing that we're talking about, being really upfront and honest about what our actual opportunities are here. These are the recommendations pulled from the National Jewish Report, that blue one on the slide where it had the two Quitline reports. These are recommendations that we made to the Quitline itself, but there's a lot of recommendations in here that apply directly to organizations. And the chief one is that first one. We really want to promote the Quitline to the people who are going to be promoting the Quitline to the clients. We really want to sell them on the idea that this is a good intervention, that it works with really high success. Quitline successes have a wide range, state by state and year by year, but they're always hovering north of 25%, sometimes getting closer to 30% and above, which doesn't sound real high, but those of you who've been with us since the beginning know that when you're looking at 25, 30% success rates in cessation measured at 6 to 12 months, that's really as big as it gets. That's as high as that number is ever likely to get for us. And so while there's always going to be more bad news than good news with a Quitline referral, we need to keep it in perspective that the two things. One is that this person's experience with the Quitline doesn't necessarily have to be their last one, and the next one might be the good one. And also, we have to also remember that Quitline services change all the time. New protocols are developed. As Chad mentioned, a lot of Quitlines right now are developing brand new behavioral health related protocols that are expanding the types of diagnoses that they're able to tailor their care around. These are important alterations, and it really means that the Quitline that somebody with a behavioral health diagnosis called in 2019 will not be the same Quitline they called in 2021. So we really want the healthcare providers or the people making those referrals to really be bought in so that they can provide an enthusiastic, warm response, because providing that level of confidence and empowerment to our smokers is the best way for them to engage accurately and commit themselves to that quit attempt and eventually be successful with it. Along the same lines, whoever's making that Quitline referral really needs to be educating around what that experience is going to look like for them, and trying to build that trust, understanding, and transparency. Really, when we interview folks, and Derek did this with our that National Jewish Report, one of the things that we really found, especially in our rural communities, our low SES communities, and a couple of very select ethnic and racial minority groups, that there's a lot of preemptive mistrust, that the coaches on the other end of the line aren't going to look like me. They're not going to understand, my unique needs. They're not going to know what things are like around here, those kinds of things. And we really need to explain to them, or try to maybe explain's probably the wrong word, but really ensure them that that's not the case. So the coaches really come from these populations, right? If you call the ash line, you're going to get Arizonans. And if you're not familiar with the health neighborhood, we can talk about that during Q&A. But by implementing a Quitline referral process, you really are embedding yourself in the health neighborhood. And the only next step is making sure that other organizations that may refer to you know that you're providing that service. The rest of these things are things that Chad's really already talked about in his part. We know that tailored care works, and we want our Quitline referrals to be tailored, and we already know that on the other side, the Quitline is tailoring care for a variety of different demographies. So we're all on the same page on that last one. And then so finally, I'm going to transfer the mic over to Mark. Mark, I am hitting the allow to talk button, and so you can address us at will. Thank you all.
Jim, thank you so much. And Chad, thank you for inviting myself and members of my team to join you today. We are very pleased to be here and welcome the opportunity to support the work that you and your team are doing to enhance and strengthen the justice-involved work that our partners here in Arizona are doing at the local level. So what I can do is I believe we just have the one slide for today's presentation. And for those of you who might not be familiar with the ASH line, the Arizona Smokers Helpline is part of the Center for Tobacco Cessation at the University of Arizona. It's been the state-funded Quitline for over 20 years. In addition to the ASH line, we have a training institute, our research and evaluation data team service, and we also have our public-private partnership initiative that we work on supporting sustainability and reinvestment into the center and the ASH line services that we provide. So for those of you that are familiar, and more specifically with the contract that we are funded to support through the Arizona Department of Health Services, one of the items that's included in our scope of work is to provide cessation services supports to the behavioral intervention components and the work that's being done within the justice-involved populations across the state. And we know, based on Chad and Jim's overview and previous discussion, that what this looks like from one local community to another is very likely to be quite different, and that there are many different types of approaches and interventions that can be used successfully to reach and engage and support the quit attempts of this population. And so, what we see as our primary role is delivering on the components that we are required to within our contract, but really working as an adjunct or an extension of the primary work that Chad and Jim are playing as the lead contracted technical assistance advisors to the state, and the work that they're doing with you at the local level. And so, how can we do that? We can do that in a variety of ways, with the overall goal of improving the reach, right? So, as Chad mentioned, reaching not only the justice-involved population, but other priority populations can be challenging, and we need to explore all viable options to reaching and engaging folks, to educate them about the services that we provide and the benefits that come along with them. And then once they arrive at our door, so to speak, what the process looks like. And Jim made a very good point that it's absolutely critical for folks to develop a strong sense of trust in who we are and the services that we provide, because making a decision to reach out for help in any context is a big ask, and particularly when you're dealing with a chronic relapsing conditions such as tobacco use and dependence. So with that in mind, we find that supporting this project and all other projects is very context specific. Chad did a very nice job of providing an overview at a national kind of a high level, and then Jim took it down to some examples of some very fine work that was happening, with the National Jewish Health Report, which, if you haven't read it, I strongly encourage everyone to read that document. It's very informative and applicable to Arizona. But what we know kind of at the within state or the county community level is that the needs of the communities and the individuals that reside at those lower levels or more specific levels tend to be much more specific. And so it's important for us to work with you to better identify those populations and assess kind of where those populations are and what capacity is available in the community or within the health department to support these communities and individuals who are interested in supporting referral development and cessation through the ASH line or other evidence-based resources that we can plug folks into. And that might include training. Mark is engaged with every county multiple times over the last fiscal year and into this one, developed a very nice set of training and education pieces for you all to participate in and extend out into practice within your respective communities. One other key component of the conversation and one area that we can support is data needs. And so, I know that Mark Bolt has mentioned that, we are available to have conversations with you on how we can best meet the needs of your communities through data. Jim had mentioned the importance of setting up referral locations to better support not only engagement at a very localized level within a particular setting, but ensuring that the activities and the energies that are invested in supporting the 5 A's or the 3 A's within a facility or a particular context need to be connected to the services that are being referred to, and that that highlights and underscores the importance of us being able to report back to those facilities the extent to which those referrals are being received and the services that are being utilized. And Mark can certainly talk in more detail about the referral process and setting up a referral location. But that is something that we certainly can do and work with you on setting up. There are other things that we can do as well. I mean, Maureen Malasso, our clinical services manager, has direct experience working within a behavioral health setting and specific training in social work and motivational interviewing, cognitive behavioral therapy, other therapeutic interventions that not only justice-involved populations, but other priority populations are responsive to. And it's important for us to mention that the clinical protocols that we put in place and develop and evolve over time are informed by the interactions that we have with our clients and are designed to meet and be responsive to a wide range of client types, if you will. So not only the specific protocols that we develop for pregnant postpartum clients, for example, but clients that would fall into a more generalized category such as low SES. That within that category, they're very likely to see a high proportion of clients who have another chronic condition such as mental health disorder or substance use disorder. So, any and all opportunities that we can have to educate you all on the services that we provide and also educate and train you using training and education pieces that we've developed that are more Arizona centric, that are informed by what's happening at the national stage and guided by those best practice principles that NAC and other subject matter expert organizations and individuals have developed over time. We just want to reassure you that we are here and available to support that work. And we'll work closely with Chad and Jim and the rest of the behavioral health and wellness team to support the projects that you're working on. And that can take a number of forms, being present at meetings, reviewing action plans, setting up referral locations. One thing that I think is kind of an undercurrent in everything that we do is it's important for us to meet our partners and our clients where they are and find common ground and build a strategic path forward from that common space. As Jim had mentioned that, it's important to chart a course forward, and sometimes you just kind of do need to jump in and roll up the sleeves and start working and then see what adjustments might need to be made. But we do think that it's important to think critically about the work that you are going to do and how you're going to do it and what benchmarks and expectations and goals that you have, and how do you develop the strategic steps to get there and evaluate your success. So I do believe that Mark Bolt, the director of the Center's Training Institute, has joined us today, as has Maureen Malasso, our clinical services manager. So I'm going to go ahead and stop right there, and we'll just make ourselves available to discuss any questions or comments that folks have. So thank you.
Sorry, it took me a little bit of time there to find my mute button or my unmute button. Thank you very much, Mark. So I guess at this point we can open it up for questions, comments from everybody. If you have something you'd like to say, just if you want to raise your hand, I can push the allow to talk button. That's what Zoom gives me the power to do. Or you can just chat your questions into the chat box or use the Q&A box. A lot of good material here from Chad, Mark, and hopefully me too. But otherwise, yeah, I'll just be quiet and wait for those questions to just roll in. Oh, we have a raised hand from Joanne. Joanne, I have hit the allow to talk button. You should be able to access your mic now.
Okay, can you hear me?
We can.
My concern is with, I'm trying to gather all my thoughts as I'm going through this presentation. So we're talking about training people in referring services to either, tobacco cessation or, maybe other programs where it would be helpful, but specifically in dealing with the SMI population, is there some kind of training or some kind of benchmark that people know when it becomes a point when it is beyond their level of experience, so that they don't tend to become too involved to the point where they put themselves in danger? Specifically, what I'm talking about is back before, when we used to have the ash line, and there was a situation where, the local health departments had the availability to the NRT that was being given, but the counselors were actually were receiving their counseling through, the telephone at that time, is because the internet wasn't so widely available. We actually had people with severe mental health issues that were coming in demanding or even experiencing like volatile conditions, where the people at the health department were just not equipped and trained to deal with those type of outbursts. And they couldn't just say, okay, well, you need to call the ash line then, because the people were, they had gotten to a point in their illness where, it needed professional control. So I guess what I'm saying is, do you believe that there needs to be that certain amount of training when dealing with people who are going to be referring to a smoking cessation program, and they're dealing with the SMI population, that they know when to ask for more advanced help?
I think I understand your question. I'm gonna restate it to make sure that I understand it. You can tell me if I screwed it up. Okay.
Okay.
And so what we have here is somebody, the patient client, the smoker who is theoretically supposed to receive an ash line referral. This person is SMI, the serious mental illness, or maybe serious and persistent mental illness, and maybe at the moment that we would be maybe engaging in this referral, they're in an agitated or a ramped up state in some way that it sort of exceeds the mental health training or the behavioral health training of the person who's supposed to be making that referral. What
Exactly.
happens? Okay. So I have a response, but I think that I would prefer if Dr. Morse, do you want to take a crack at this, since you are the person, the resident individual with a semi experience on the line?
Sure. Yeah. And we do quite a bit of this training, both on the Quitline coaching staff, but also on the community staff, and basically there does have to be some level of training with whoever would be providing those referrals to understand when a referral would be appropriate or not appropriate based on the system, or I'm sorry, the symptom level at that point in time. So there's obviously going to be times when a Quitline referral is not in the best interest of someone, and whether it's the patient or the system that's referring. And so it's really some basic assessment in teaching some basic assessment in that regard. But also, we highly recommend that within those community settings that are referring, they have at least some staff that have more specialty in behavioral health issues? Are the individuals making that referral, or have that training? So maybe it's not really the public health system that should be making that referral. Maybe it's the behavioral health sector that should be making that referral. But yeah, I mean, there's definitely some guidance and training that's involved there, to make sure that if someone's really in an exacerbated symptom, has exacerbated symptom levels, that you're not referring them to a Quitline, because they're not going to benefit from that. It might, it might actually worsen their symptoms in some regards. The Quitline's not going to be able to work with them efficiently. So I don't know. Am I getting at your question, Joanne?
Yeah, I think the bigger concern that I have is when you have people in multiple skill levels, dealing with the same patient. So let's just say that this person is dealing with a Quitline, and a qualified counselor who knows how to maneuver their behaviors and their mood changes and stuff. But then they say, but we also work in collaboration with your local health department. So go to your local health department, and you can receive as we said in the past, the way we did it, you could receive your NRT there.
Mm-hmm.
Well, then you have the people that are dispersing the NRT that are not at the level as.
Yeah. So, I mean, I think that going back to that workflow chart that Jim put up, and the workflow chart that Jim put up was kind of for one agency, but there's absolutely no reason why you can't be looking at workflows across, like a team-based approach across agencies. So basically, I think it would be the responsibility on the behavioral health side to make sure they're not sending you, the public health folks, individuals that aren't appropriate or aren't ready for that referral.
Got it.
Yeah, I'm just going to reiterate how I would have responded to that question, which I think is in line with Dr. Morris's response. One is always practice within your scope, right? And if you're not really trained to be dealing with agitated patients, like in the middle of a psychotic break, or expressing suicidality or self-harm, then you really need to be passing that individual off to the person who can rightfully respond. They're not ready for that Quitline or that Ashline referral. And then the flip side of that is, I want to disaggregate that particular question from just tobacco related questions in general, that, if you would also, somebody might be working with a high intensity needs SMPI patient, and also needing to connect that person to housing support or food stamps. And they're going to send them to the public health department for those things too. So theoretically, there's already a protocol for making sure that person's mental state is controlled and balanced and appropriately medicated, et cetera, before that particular protocol is engaged. And so I would assume that the same thing can be done with the Ashline, which is just another way of saying that we want to be aligning our tobacco processes with other processes that are similar but not identical to the tobacco process.
And I know it looks like, Jim, we have about one more minute, but there's one more question maybe we could get at from Susan Williams. What does Ashline services look like for incarcerated individuals? Age CCCS is discontinuing until they are released. Is discontinued until they are released.
That's the state Medicaid office.
Right. Yeah, and so what's happening, which is nice, is that they're getting those benefits before they're released now, or they have that capacity. So they're set up, they roll in, and they can get the Medicaid benefit right away. And the Ashline services, right off the bat, is really going to look similar to the general population. If they have behavioral health issues, it's really Mark's team that's going to make that assessment about how they, based on their intro questions, they're asking how they need to tailor their treatment. I don't know, Mark, if you want to say anything on that.
Yeah, thanks, Chad. And thank you for the question, Susan. So, yeah, and currently our service protocol supports a 2-week starter kit of nicotine replacement therapy, patch, lozenge, or gum, to all eligible clients, and access beneficiaries fall into that category. So, while they are in the facility, I cannot speak to what services they may have access to. I know we participated in one of the first phases of the Justice Involved pilot project with the Department of Corrections, and there were several policies and procedures that needed to be followed, and it was my understanding then, and I couldn't say if it continues, that while individuals are incarcerated, their access benefits are suspended. But once they are released, their access benefits, if they're eligible to receive them, become active. So at that point, they would certainly be eligible to receive the services that we provide, if that's helpful.
Okay, well, guys, we're about 2.5 minutes over time. I want to extend a hearty thanks to Mark and the rest of the Ashline team for joining us today, and also to the rest of you who were in attendance. If you have any other questions, please email Chad or I at our respective email addresses, or you can just go to our catch-all box pictured on the screen there. And otherwise, we'll see you at the next COP event. Thanks, everyone.